Good evening, everybody. I hope you can all hear me, and welcome to this tonight's webinar. So what we're going to talk about tonight is practical echocardiography, and I'm really going to be focusing on the standard views and the basic measurements. So this is from feedback from a lot of people in practice, something that some vets really struggle with. So I'm going to try focusing on actually getting these standard views and how to switch between the different views. So it's a very basic talk in a lot of ways. So here goes. So the topics we're going to cover tonight, we're going to start with patient preparation. We'll do a bit about probes, understanding the buttons, and then optimizing your image for echocardiography. And then we'll really focus on, as I said, the standard views, and then at the end we'll just touch on the key measurements that we do in echocardiography. So the starting point here would be that I think good hygiene is something that we should all be practicing in practice when we're doing our ultrasound scan. So I know I keep banging on about it, but clipper disinfection is important between patients, making sure that your blades are maintained properly and that they're not damaged, that they're not going to damage the skin, and that you actually disinfect your probes between patients as well. It's just good hygiene practice. And then if we just touch on the driving of your ultrasound machine, starting point is going to be to press the cardiology preset. And the preset for cardiology is completely different to abdominal ultrasound scan. It requires a high frame rate and good contrast between blood and tissue. And this is a video of a cat that you can see on the right. I hope you can see this. But this is a cat whose heart rate is something like 300 beats a minute or above. And this is the reason why you need high heart rates, or sorry, high frame rates for doing echocardiography. And then I've talked about this before, but the 4 magic buttons. So these are the 4 main buttons that you would be toggling between when you're doing an echo. Maybe not quite so much as you would with an abdominal ultrasound scan, but you'd certainly want to adjust the depth, the gain, the time gain compensation, and the focus. And then don't forget the zoom button. I think the zoom on ultrasound machines is a great thing. It's very underused in practice. And it's great just to allow you to zoom into an area of interest and really see the fine detail in your echo. So in the example here, we're just looking at the mitral valve. This is a left apical 4-chamber view. And I've used the zoom just to really focus in and have a look at the mitral valve and see how thick it is or how thin it is, or it's actually normal because it's my dog. And then a little bit about probes. The probe that you can see in the middle here would be your standard kind of middling frequency probe, and that would be the type of probe that most vets would have in practice. I think there are times where you need to use a lower frequency probe like the one on the left here to allow you to get better depth. And then if you're looking for really fine resolution, you might be wanting to use a higher frequency probe for puppies and kittens and cats. So I've got a good example of this. The next video is from a dog that I saw. I was running a course just before lockdown. And getting towards the end of the day, they said, would you mind scanning this dog de Bordeaux for us? It was a Mastiff or a dog de Bordeaux, I can't remember now. And they couldn't get an image of this dog's heart at all. So I tried changing the frequency just to allow the depth of penetration, and really struggled with it. So I brought in my own machine and a lower frequency probe. So this probe runs between 1 and 5 megahertz. And as soon as I put the probe on, you could see what was going on in this case. So this is a dog with a heart-based mass, a massive heart-based mass. If you look at the centimetre markings down the left-hand side here, this is 15 centimetres to that point. So, you know, you really need a lower frequency probe really to get the depth of penetration required in a big dog. And then what about preparing our patients? what you should be doing is clipping the thorax and just under the elbow. And what I would say is, make sure you get permission, that the owner's aware where you're going to be clipping. And what I also find in practice is that a lot of vets don't actually clip far enough sternally. So when you see a dog that's been clipped for an echo and it's been clipped right up here towards the top of the chest wall, that's too high. You need to be really clipping right down sternally, because that's where you're going to put your probe. And then to prepare the skin, I certainly use spirit and then wipe down to degrease the skin, but make sure you dry it thoroughly so that the spirit does not ever come in contact with your ultrasound probes, because there are some models and some makes where spirit really can damage the probe. If you're not sure, just don't use spirit at all, or at least talk to the manufacturers, get the advice from them. And then preparing for the scan, I always do my echoes with a table with a cutout. So what you can see in the middle at the bottom here is a homemade table. That was my first model table that I had for doing my echoes. And that's evolved now into, well, I've purchased this table that you can see here. But why do we use a table with a cutout? It's so that if you have the dog in left or right lateral recumbency, the heart flops against the body wall and it pushes the lung out the way, and it improves the size of the window. So it makes it easier to get good imaging. You can do some dogs in a standing position and cats, but it's a lot more challenging to do that. So have them on a table with a cutout ideally, and scan from below. I use lots of magic spray like this Feliway or Adaptil or Pet Remedy or anything like that. I think it does make a difference in terms of calming your patient, and I'll actually spray it long before I actually do my echo if possible. And then the other thing to think about is that you want to be doing that echo in a room that's not going to be disturbed, and a room that's quiet within the practice. That's not always easy. Sedation, do we actually sedate? I try not to if I can avoid it. So I spend lots of time making sure that my patient's comfortable and that they're handled gently, and that I'm using lots of Feliway or Adaptil, and making sure that the nurses, when they're holding, that they're not holding too firmly. I think less is more in that sort of case. So I do try not to sedate if I can possibly do it. In fact, I was in a practice the other day, and I've been going there for what, 2 years now, almost every couple of weeks, and I sedated my first case there just last week. So that shows you just how often I do reach for sedatives. So if you have to sedate, you want to be reaching for something that's not going to have any cardiovascular effect. So they talk about butorphanol, alfaxan, IM, off-license, gabapentin, and there's probably more than that as well. The other thing to think about is having the room as cool as possible as well, because the last thing you want in a hot summer's day is to try to do an echo in a dog that's panting. It's an absolute nightmare. So that's preparation. So if we then talk about the standard echocardiographic views, there are 4 echo windows that are talked about in the textbooks and that we use, I use on a daily basis. And these are the right parasternal, which is between the third and sixth intercostal spaces, the left apical and the left cranial windows, and the subcostal window, which is the one that we use for measuring aortic outflow. And that's one that's not used in most cats because there's a bit of lung that tends to get in the way of getting a good image. So if we start with the right parasternal long axis view, so that would be your main starting view for doing an echo. And if you look at the top right of the screen, there's a QR code which has got a link to my YouTube channel. And I put up some videos of the standard views, years and years and years ago, but I checked the link the other way. So if you use your phone and scan that QR code. It should take you to the YouTube channel to allow you to have a look at these views. But basically, to get that right parasternal long axis view, what you do is you feel for the apex beat, and then you put your probe on there, and that's your starting point. And this is the view that you would be trying to achieve from that first, when you first put your probe on. So the standard orientation that we talk about is having the left atrium to the right of the screen and the left ventricle to the left of the screen. And then if I just go through some of the structures that you would expect to see. So the left atrium, you can see here, there's a pulmonary vein just entering the left atrium to the right of the screen. The mitral valve, and that's attached to the chordae tendineae, which are attached to the papillary muscles. That is not a tumour, that is a papillary muscle. And I quite often get people sending me videos or photos asking me to confirm whether or not that's a tumour in the left ventricle. Yeah, it's commonplace to see a papillary muscle in the left ventricle. This is the left ventricular free wall, or we call it the left ventricular posterior wall, the interventricular septum, the right ventricle, the right ventricular free wall, the tricuspid valve, the right atrium, and the interatrial septum. So that's the basic anatomy of that view. And here's what it looks like. So this is Nell, my dog, and I used her to take a lot of these views that you're going to see tonight. So that's your right parasternal long axis view. We also call that the inflow view, as in the mitral inflow view, because it's optimizing the mitral valve. So how do we actually get that view? My starting point, once I've felt for the apex beat with my left hand, what I do is have my finger on the button. I like to have my thumb on the button to get that standard view, but you do have to have your left-right invert activated for that to work. Otherwise, if that's completely confusing to you, what I would say is don't bother activating your left-right invert, but if you just realize that you need to have your probe 180 degrees the other way, so your thumb's not actually on the button, it's your finger, your index finger, that's on the button. And the other thing to think about is that you need to be fanning just slightly caudally to optimize the left atrium to get that first view. Before we go any further, it's probably worthwhile just talking about the probe motions, because that's really important that you understand that in echocardiography. I think that's actually where a lot of people go wrong. So the sorts of motions for echocardiography, by the way, when we're talking about echocardiography and movements, hand movements, they're very gentle movements, very small, slight movements that you need to do. It's not like scanning an abdomen where you're making quite fast movements. You want to do small, carefully considered movements. But they are, from the left, fanning and fanning. So this is my mock-up of fanning. So here is a... The next one is rotation. And we use rotation to swap between long axis and short axis views. So this is rotation. Okay. The next one is a rocking motion. And you can see here, rocking. On short axis views, we use rocking to bring the heart to the left of the screen, or to the center of the screen, or to the right of the screen. And that's a really useful technique that we use for echocardiography. And then the last one is sliding. So this is, remember, this is a mock-up. So this is sliding up the body wall or down the body wall. Why would you slide up or down the body wall? Well, certainly if you find that you've gone too far up the body wall, what you find is that you get breakout because the lungs get in the way, and that interferes with your window. So one of the techniques is to slide the probe back towards yourself to to improve your image optimization. The other thing that you might use to slide the probe up the body wall for is to change the angle that you're viewing the heart in the long axis view. So to get the heart absolutely perpendicular and get these textbook images, you tend to have to slide the probe up the body wall to get these. So once you get these into your head, so that was sliding, rocking, rotation, and fanning. Okay. So we've talked about the right parasternal long axis inflow view, where we're optimizing the mitral valve. That's the image on the left. The next view on the long axis that you want to try and achieve is the right parasternal long axis outflow view. So that's optimizing the aortic outflow, the left ventricular outflow tract and the aortic outflow. And the technique for that is to use an anti...
2, 1.
Hear me now? Is an anti-clockwise rotation. So it's 10 to 15 degrees. I'm just going to play that again. 10 to 15 degrees anti-rotation. 3, 2, 1. There we go. And what you quite often find, it depends on the dog as well and the size of the dog, but sometimes you find you have to, as well as rotating anti-clockwise, you have to fan cranially to optimize the aortic outflow. So just be aware of that, but it's something that you need to practice and use your hand-eye coordination to change between these views. Okay, so what do we see with the right parasternal long axis outflow view? Well, you quite often will still see the left atrium, the chordae tendineae, the left ventricular chamber. You'll see the left ventricular outflow tract, and you will see the aorta. And the aorta usually, it always sits in the middle of the heart, but usually you can see a bright white echo in the middle, which is the aortic valve leaflets. And I always think the root of the aorta looks a bit like a daffodil bulb. I'll just play the video on the next slide. You can see what I mean by that. So the aorta comes down into the aortic root and it widens out at this point here. And that's the sinus of Valsalva, that widened point that you can see here. And as I say, I always think it looks a bit like a daffodil bulb as it widens out at that point. So what's important to have a look at in this region, you'll sometimes see a ventricular septal defect in this region. Obviously you need colour flow to absolutely confirm it. But if I was looking for a VSD, a lot of vets, a lot of people, would look for a muscular VSD, but the more common ones that we find are perimembranous or supracrystal, and you find them in this region here, just under the aortic valve, or actually in this point here as well. So that's the right parasternal long axis outflow view. And then in terms of eyeballing that, so once you've managed to master these two views, what I would say is that if you're a complete novice to this and you're really not sure what you're looking at, then what I would do is just sit back and just take in what you're seeing. So I would eyeball the right parasternal long axis view and the right parasternal long axis outflow view as well. And I'd be asking the questions, is the interventricular septum straight? Is the interatrial septum straight? They should be straight, but if they're curving over to the right, that may suggest that you've got a left ventricular problem and that you've got an enlargement of the left side. If the interventricular septum is curving towards the left side, it may suggest that you've got a right-sided problem. And the same would apply for the interatrial septum as well. So eyeballing the aorta and the left atrium, they tend to be similar in size, or certainly if we talk about ratios, I would expect the left atrium to be about 1.3 to 1 of the aorta. So very similar in sizes. So if the left atrium eyeballs and it's 2.5, 3 times the size of the aorta, then I would be thinking that's got to be enlarged, but we need to measure it to make sure. And then we'd look at the mitral valves. Are they thickened? Do we have mitral valve disease, or are they thin? Are they normal? How well do they open? Does the septal leaflet of the mitral valve come all the way to the interventricular septum, or does it just open a little bit? Is it a DCM case or is it not? I then look at the aortic outflow and see whether the left ventricular outflow tract looks normal or not. So some of these cats with hypertrophic obstructive cardiomyopathy will have a hump in the septum, what I call a dippy septum, in this region here at the left ventricular outflow tract. You might see nodules with subaortic stenosis as well. Again, you need colour flow Doppler to help you with that. And then I would look at the left ventricular free wall and the interventricular septum, and that's just making a judgment as to whether you've got myocardial thickening or not. The right side of the heart, if we're eyeballing the right side of the heart, I would expect the right ventricular chamber to be about 1/3 of the size of the left ventricular chamber. And I would also expect the right ventricular free wall, this one here, to be about 1/2 the thickness of the left ventricular free wall. And then I would look at mitral valve motion. I'd look at left ventricular chamber motion. So is it normal? Is it hypokinetic? Or is it hyperdynamic? And then the last thing we'll always forget to look at, a bit like reading x-rays from the outside to the inside, but look at the myocardium, look for any myocardial lesions, look at the endocardium, especially in cats, look at the pericardium. Is there pericardial effusion? Are there any lesions within the pericardium? So just eyeballing, if you can master these two views and you eyeball it, there's a huge amount of information that you can get from that. So really, really useful to master these two views. And I would say I would spend my time trying to master these before you move on to the next views. And other things that are useful in terms of echocardiography and trying to work out what you're seeing, if you press the freeze button on any ultrasound machine, you'll find that you can scroll back, or you can play loops of video back. And if you go through the settings, you'll find that you can actually play back in slow motion. And that's really useful when you've got a fast moving mitral valve and you're finding it difficult to decide whether it's thickened or not. So these mitral valve disease cases, it's great for that. Press your freeze button and play a slow motion replay loop so that you can see a bit more of the mitral valve detail. The other thing that we need to understand is that the mitral valve actually opens in 2 different waves. The first wave is the E wave, what we call the E wave, and that represents early diastolic passive filling. And once the left ventricle fills with blood, and once it's full of blood, what you see is the mitral valve starts to come back towards the center. And then the P wave on your ECG causes atrial contraction. And then you get this A wave, which is the atrial kick. So there's 2 motions to the mitral valve. I'll just play this video so that you can see that. So systole, and then we have an E wave back to the middle, and then an A wave, and then systole again. So there's 2 motions to that: E wave, A wave, systole. Okay, that becomes important when we start to look at measurements and other bits and pieces of fine detail when we're looking at echoes. We'll maybe not go into that too much today, but it's something that we may look at in following lectures. So, okay, that was the right parasternal long axis views. The next thing that we want to do is then switch from the long axis to the short axis views, and to be able to do that, you do the thumb to bum maneuver. And the thumb to bum maneuver, I'm going to play a video of that, but before I do that, just to get your orientation, this is Nell on the table. Her head is to the left of the screen and her tail is to the right of the screen, so she's in right lateral recumbency. And you can see my hand, I've got my thumb on the button at the moment, so I'm optimizing the right parasternal long axis view, and I'm now going to change to the right parasternal short axis view. So I'm going to do a thumb to bum maneuver. My thumb is going to head towards Nell's bum, so it's going to head caudally. So here it comes, thumb to bum. And that's how you swap from a long axis to short axis view. Here it comes again, thumb to bum. And what you need to do is you need to maintain that axis that you've got there. Don't change that. If you change that, you'll go off and you'll lose your image altogether. So it's really important that you maintain that axis. And in actual fact, one of the things that I sometimes will teach is that if you're finding it difficult to twist the thumb to the bum and your wrist is twisting the angle here, then the alternative way to do your thumb to bum is to take the probe in your left hand, twist it, and then grab it again with your right hand so that you maintain that orientation as you do the twist. It's really important. So that's thumb to bum. So once you get the short axis views, then what you do is you use a fanning technique to fan from the apex of the heart all the way up to the base. So that's the apex going through these different views all the way to the heart base at the top. So to fan through the short axis views, what you have to do is, and I'll show you the video as well, it's a combination of fanning and rotation. It's not just fanning on its own. And when you're fanning, what you're wanting to do is to point your probe towards the dog's left shoulder. That's the general direction of fanning. But it's a fanning and rotation. If you don't do the rotation, what you'll find is you'll get oblique short axis views, and they're just wrong. They're not right at all. So here it is. So we're in the short axis view, and we're now fanning dorsally, and we're rotating, and back to the beginning again. So fanning and a little bit of rotation. I hope that makes sense to you all. Okay, so here's what these short axis views look like. So here's the first view that you get, and this view is optimizing the papillary muscles, the two papillary muscles that you can see. And I sometimes call this the mushroom view, or lots of cardiologists call this the mushroom view, because it looks a bit like a mushroom. The next view up from that is the chordae tendineae, and the chordae tendineae you see as little dots. So here's the little dots that you can see here. So that's the tendineae in cross section. And this view is important because that's the view where you would take your M-mode measurements to measure the left ventricle. And I'll show you how to do that a bit later on. The next level up from that is the mitral valve view. And this is sometimes called the fish mouth view because it looks a bit like goldfish lips. So here's the mitral valve fish mouth view. And again, if you want to if the motion's too fast for you and you want to see a little bit more detail, then one of the things you can do is play back in slow motion, just like we talked about before. It's a really useful thing to do. The other thing that you can actually do, I don't know if you noticed that the sector width here I've dropped down a little bit. And the sector width, if you drop it down, it can actually increase the frame rate. It's more relevant to old-fashioned machines, old machines. But I still do it. I don't think about it. I just do it because that's what we used to have to do in the old days to get the appropriate frame rate. So that's that. And then the next view up from that is the optimizing the aorta and the left atrium, and we call this the Mercedes-Benz view, and that's because when you look at the aorta sitting in the middle of the heart, it looks a little bit like a Mercedes-Benz. And here we are, this is Nell's aorta that you can see here, and there's the left atrium, and it tends to be, I think of it as being a bit of a comma shape. So there's the dot of your comma, and there's the tail of your comma. So here's the left atrium, and that's the left auricular appendage, that pointy bit there. Aorta in the middle, so there's three cusps of the aortic valve, tricuspid valve that you can see at the top at 12 o'clock, and this is the right ventricular outflow tract running down here, and you can just see the pulmonic valve in the 4 o'clock position there. Okay, the other thing just to point out in terms of eyeballing it is that some textbooks talk about the left atrium. If it becomes sausage shape, it suggests left atrial enlargement. I never quite got that, but I think what that means is that you lose this pointy bit at the end, which is the left auricular appendage, and it becomes quite a lot more widened when you've got an enlarged left atrium. And we'll talk about how you measure the size of the left atrium a little bit further along the line in this lecture. And then the next view, if we're going right up towards the heart base, is where we try to optimize the pulmonic valve and the pulmonary artery, the main pulmonary artery. Nell's quite difficult. She's got quite a tight squeeze to find her pulmonic valve, and it's just because of the shape of her chest. But when you get this view, what I would be thinking about in terms of eyeballing is to look at the size of the aorta and the pulmonic valve, and they should be similar in size. As a ratio, they should be 1 to 1. So if that ratio is abnormal, I would be wanting to know why. And then, so that was the views from the right. And again, what I would say is that if you're learning, learn the right-sided views first before you go to the start learning the left-sided views. Excuse me. So the left-sided views are useful for Doppler studies, and that's because there's good alignment with flow. What you find is that the wall definition, excuse me, is less crisp. What you do is you feel for the apex beat, and your probe position needs to be quite sternal for left apical views. Excuse me.
I had to offer you a glass of water then, Mark.
So here's a left apical 4-chamber view that you can see here. And what you can see is that that is optimizing the mitral valve. So in terms of Doppler studies, you're staring right down the barrel of the mitral valve leaflet. And I've talked before about using that rocking movement or rocking motion. If you use that rocking motion, you can actually bring the tricuspid valve to the center as well for getting good alignment with the tricuspid valve. And then if you tilt just ever so slightly and rotate, then you can optimize the left apical 5-chamber view. And again, that gives you good alignment with flow for doing Doppler studies. So that's the left apical 5-chamber view. And again, that's called an outflow view because it's optimizing the aortic outflow. And then there are short axis views. So this is a left cranial short axis view here. And so what you can see in this view is the left atrium, sorry, the right atrium, the tricuspid valve, the right ventricle, the aorta always sits in the middle. And in Nell, you couldn't actually see both of the tricuspid valve and the pulmonary artery at the same time. So in this video, what you can see me doing is just swapping between the two. So here's the tricuspid valve, right atrium, right ventricle, and here's the pulmonic valve just coming, pulmonic outflow just there. Just show it here again, there's pulmonic valve there, pulmonic outflow. So that's the left cranial short axis view. There is another view that I find really useful for optimizing the view through a patent ductus arteriosus, and I'll just mention it in here in passing. So what you do, we know that a PDA sits between the pulmonary artery and the aorta, and that we're going to find that PDA by scanning a cross between where the aorta and the pulmonary artery cross. So in sweeping between this view, it's a left cranial with extreme dorsal angulation. It's described in the JVC in 2016 here. But what I'm doing here is I'm scanning and sweeping from a ventral position and sweeping dorsally. And as I sweep extremely dorsally, you get this view here where you can see the pulmonary artery, pulmonic valve, pulmonary artery, and the PDA you would expect to see in this position. Again, you need colour flow for this, but this is one that is worthwhile learning as you're learning your views. So here it is. Here's the aorta. Here's the tricuspid valve, and then here's the pulmonic valve. So once you find that view, is you hold it so that you can actually see the pulmonic valve and the pulmonary and the PDA, if there was a PDA in that position. You can actually use that for doing pulmonic outflow as well, pulmonic outflow velocities. And then subcostal view, we use that for looking at aortic outflow. So what you can see here is the aortic valve. You can see the sinus of Valsalva in this position here. So that's that widening out, that daffodil bulb that I talked about before, left ventricle. So to get that aortic outflow view from the subcostal location, you position your probe within the abdomen and you're pointing your thumb towards the dog's head. So you're pointing cranially. And it's quite a difficult one to master. You're scanning it quite a depth, so your image quality is never going to be that good. But once you get your eye in for it, you can see the aortic valve. And then what you do is you drop your line this is a continuous wave Doppler line, and we've got the focal point just in here, just beyond the aortic valve. And if I play the video, it'll make a bit more sense. So here we are, we're just about to press a continuous wave Doppler, and then here's our continuous wave. So there's aortic outflow on continuous Doppler. So that's why we use that subcostal view, and that's what it's important for. Okay, so once we've mastered these views, we need to start thinking about if we've eyeballed, let's say, a left atrial enlargement or left ventricular enlargement, we want to then go on and prove that it's enlarged, the left atrium's enlarged or the left ventricle's enlarged. And the way that you do that is by measuring. So we'll talk about evaluation of size. So if we just keep it simple, what I would say is that the real key measurements in terms of echocardiography would be the left ventricular internal diameter in diastole, the LVIDD, and that can give you an idea as to whether you've got a volume overload situation. So the LVIDD is a key measurement in looking for heart enlargement, cardiomegaly in dogs with mitral valve disease. The next one is the LVIDS, the left ventricular internal diameter in systole. And that's a key measurement in terms of reduced systolic function. So as systolic function reduces, the LVIDS starts to increase. So it can be an indicator of reduced systolic function. So DCM would be the diagnosis that would be most applicable to. And then we use the left atrium to aortic ratio, the LAAO, and that gives us an indication of whether our left atrium is enlarged or not, or whether an animal is likely to be heading towards congestive heart failure if the left atrium is massive. And then the other key measurements we think about would be the left ventricular wall thickness, the left ventricular free wall thickness in diastole, and the interventricular septum in diastole. So these would be important for example, diagnosing HCM in cats. So we use 6 millimeters as a cutoff for the left ventricular posterior wall and the interventricular septum for diagnosis of HCM. And it would also be applicable, for example, to an aortic stenosis where you're trying to see whether you've got pressure overload or not, or evidence of pressure overload. So that would be your key echocardiographic measurements. Why bother? Why is it important? Or is it important? Certainly when the EPIC study was published, what they did was they used the left atrium to aortic ratio as a key indicator of whether you have left atrial enlargement, and they used a ratio of 1.6. And they also talked about a normalized left ventricular internal diameter in diastole, and they used a cutoff of 1.7. So this was for determining whether a dog was stage B1 mitral valve disease or stage B2 mitral valve disease, i.e. they've got evidence of cardiomegaly. So if they've got cardiomegaly, you would expect to see a big left atrium and a big left ventricle. So how do we actually do that? How do we measure these things? Measuring a left ventricle, it has to be performed precisely. Otherwise, you're just measuring nonsense, and we don't want to do that. So here's how you do it. So when you have got that view, short axis view through the left ventricle at the level of the chordae tendineae, what you do is you press your M mode button and then you use your tracker ball to line up so you're bisecting the left ventricle. And this is what M mode looks like, if you can see that. This is what M mode looks like when you're taking an M mode. So how do we do that, and how do we make sure that we're doing it correctly and we're doing it precisely? It's really important that it's done properly. So here's the rules, okay? So number one, the M mode must be taken at the level of the chordae tendineae, so you must be able to see the chordae tendineae. The next rule is that you must truly bisect the left ventricle, so that if you draw a line down where your M mode cursor is, I would expect the left side to be a mirror image of the right side. If it's not, then I would suggest that your angulation is not correct, and that you've gone slightly oblique. And so therefore what you need to be thinking about is rotating either one way or the other to bring it back into the correct position. So you must truly bisect the left ventricle. And you must be prepared to say, I'm not going to accept that, it's not right, because your measurements are so crucial that it's done accurately. And then when you take your measurements, you take your measurements in diastole. So diastole is the Q of the QRS complex, or it's when it's just before systole. It's when the left ventricle is at its maximum capacity. So we measure the interventricular septum in diastole, and then we measure the left ventricular internal diameter in diastole, and then we measure the left ventricular posterior wall in diastole, and then we take our systolic measurements. Now, for the purposes of this illustration, what I've actually done is I've moved it along. So what you can see, I've chosen to use this one here. You would actually be using this piece here to take your measurements for the septum. So I hope that makes sense. So diastole, systole. Okay, so here's the systolic one. Interventricular septum in systole, left ventricular internal diameter in systole, and left ventricular posterior wall in systole. And we use something called the leading edge methodology. So this was described in 1978. And if you're doing a cardiology certificate, this would be your reference to refer to. But leading edge methodology basically means that you take your measurements leading edge to leading edge. So it would be leading edge to leading edge, and then leading edge to leading edge, and then leading edge to leading edge. So how do we interpret these figures? So once we've done our M mode and we've got all these figures, I think the starting point would be to look for the breed-specific reference range first. So here's one that's been published for English Springer Spaniels, and it's got all the reference values for interventricular septum and left ventricular posterior wall, and et cetera, et cetera. So if you can't find that, then the next place to look for these measurements, these reference ranges, would be to compare with the textbooks. And the one that most people use are the Cornell formulas. So it's given by weight. So if you look for the weight and then go across the table, it will give you all the measurements that you need. Or the final thing is to use normalized formulas. And this was the thing that was described in the EPIC study. And I actually use this every day in all of my cases. So this is the normalized left ventricular internal diameter. So this is really just to produce a figure that you can remember, so that irrespective of the size of the dog that you're scanning, I know that the LVIDD normalized should be 1.7 or less. Okay, or should be less than 1.7. Anything above 1.7, according to the EPIC study, is abnormal. So that's the normalized value for the left ventricular internal diameter in diastole. So on my machine, what I've done is I've plugged this formula in. So whenever I measure the LVIDD, what it does is it calculates LVIDD divided by body weight to the power of 0.294, and it just automatically gives me a figure. So instantaneously, I can look at that and say, yep, that left ventricle is bigger than it should be. So what about the left atrium? How do you measure the left atrium? There's different methods have been described, but again, the EPIC study, they tended to use the right parasternal short axis view, optimizing the aorta and the left atrium. And that was described by Mark Rishnu in 2000, and there are some other references as well that describe this. So what does that look like, or how do you do it? Well, basically, you're looking for a left atrium to aortic ratio, so a ratio of the left atrium here to the size of the aorta. And I would normally expect it to be less than 1.3 to 1. If it's getting above 1.5, it's getting big, and I would think that's that's getting towards being abnormal. In fact, in the EPIC study, they used anything that was equal to 1.6 or above represented left atrial dilation, left atrial enlargement. So how do you actually do that? What you do is you get that right parasternal short axis view, optimizing the aorta in the middle and the left atrium, and you need to be able to see all three cusps of the aortic valve leaflet. And the timing of it, you tend to take it at the first frame after aortic valve closure, and that roughly equates to the T wave if you've got an ECG running. So T wave, or the first frame after aortic valve closure. And what you do is you measure inside edge to inside edge. So the description of how to do that that you can see is here. I won't read this out, but what you're essentially doing is you're measuring across the line between the non-coronary cusp and the left coronary cusp, and it's the inside edge to the inside edge. And then if you extend that line that's created all the way into the left atrium, then that's where you take your left atrial measurement, inside edge to inside edge. And it also says here, in images where the pulmonary vein was seen entering the left atrium, you sometimes find you get a blank spot here because of the pulmonary vein in here, and then you don't know where the back wall of the left atrium is. In these cases, what you need to do is to just try and eyeball it, approximate it, so you can see where the left atrium, the left atrial wall is coming to this point, and then if you've got echo dropout at this point because there's a pulmonary vein coming in here, then I would just eyeball it and approximate it. So that's how you measure the left atrium to aortic ratio. So to summarize what we've gone through tonight, what I would say is that mastering the standard views, it takes time, it takes time, and it takes practice, and it takes patience. And you have to just practice and practice and practice until you get it right. Your measurements must be precise, so therefore the views must be correct. So again, it comes back to being able to get these views and to get them precisely. And certainly when I was learning, what I did was I laminated all the standard views and I stuck them on the wall beside the ultrasound machine. And I would say, right, okay, my job today is to try and to optimize my image of the right parasternal long axis view. And I'm not going to leave here until I've got it. And so I did that, and I just kept practicing and practicing, and then I would move on to the next view, and then I'd move on to the next view. And that took a long, long time to be able to master them all. So it's not something that I would expect you to learn overnight, okay? And then just final summary point is that the key measurements of size would be your left atrium to aortic ratio, and certainly for mitral valve disease, the left ventricular internal diameter and diastole. And if we're talking about HCM, we're interested in wall thicknesses. So, time for questions.
We've got a few questions come in here, Mark, actually.
Okay.
So,
yeah,
the first one's from Richard Rivar. It just says, could you just review the leading edge measurement slide?
Yeah, sure. Yeah. I'll just go back if that's okay. But what we mean by leading edge to leading edge, so leading edge is the first point that you see. So as you bring your cursor down to take that first measurement to plot it, it's the junction between the white and the black. So that's the first leading edge. I'll just make that a bit bigger so that you can see that. the next leading edge is the first one that you can see. And then the next leading edge from that is that point. So we call it leading edge to leading edge all the way through. And that is just so that we use a standardized method of taking measurements, if that makes sense. It's reasonably well described in this paper from 1978. If you want to dig that out, that's where I would look for it. I think it's also mentioned in the BSAVA Manual of Cardiorespiratory Medicine. You can see, yeah, the second edition, it's chapter 11, it's page 89. So if you've got that, then have a look there for it as well.
Thanks, Mark. That's great. We got a few more.
Yeah.
Alex here asks, would you ever take the LVFW thickness on the long axis view?
Yeah, I haven't gone into that tonight because I didn't want to confuse things, but yes, you can do that on the right parasternal long axis view. So if we just go back up to, let's say, this one here. So this is the left ventricular free wall that you can see here. And so if you were going to take this measurement from the right parasternal long axis view, what I would be wanting to do is to have the free wall absolutely perpendicular to the probe, to the beam. So this heart is slightly tipped up, that you can see here. So it would want to be absolutely perpendicular. And what you'd be wanting to do is take the measurement at the same position as you would on your short axis view, and it's at the level of the chordae tendineae. So if you were really struggling and to get the short axis view and to get M mode, accurate M mode, then that would be your workaround. And there are some studies with suggested measurements for the left ventricular free wall, and the all of the measurements that we talked about tonight as well.
Thanks, Mark. Another question here, quick question on HCM in cats.
Yep.
What are the estimated sizes of LV?
For the actual left ventricular chamber, can we clarify that?
Let's have a look.
So what we're more interested in with HCM is the left ventricular free wall, or the left ventricular posterior wall in diastole, and the interventricular septum in diastole. So you're looking at, we use 6 millimeters quite often as a cutoff to determine whether you've got left ventricular hypertrophy or not. Now, in cats, I use a combination of the M mode going through the short axis view, and just a B mode again going through the short axis view. So if I just move forward a few slides here, what I mean by that is, so in this view here, if you can't get a clean M mode, and that is a difficult thing to do in a cat with HCM because you get so much concentric hypertrophy, there's no left ventricular chamber. So you quite often find you a really dirty M mode image, and you can't accurately see where where the clean left ventricular free wall or interventricular septum is. So the workaround is to press the pause button in diastole in this view here. So just a B mode image, so you just scroll back until you've got diastole. Let's say it's that point there, and then you take your measurements here. So the interventricular septum there, and the left ventricular posterior wall in diastole. So that's your cheats way around, if you like. But if you actually look at the guidelines that have just been published, they talk about that in a bit more detail, and they talk about taking that with B mode rather than M mode. So it's fine to do that, if that makes sense.
Yeah, thanks, Mark. That's great, and I think that's the end of the questions.